Good afternoon, ladies and gentlemen, my colleagues. May I request the people? Microphone is okay. I'm not audible. Okay, I am audible now. No technology blip there. And may I request the audience standing outside to come into this very important session, please? And this is going to be a symposium on technology for people at high risk of type 2 diabetes. How do we apply it and what do we gain from it? I think we have three brilliant speakers who have done a lot of work. I don't want to take too much of time trying to introduce this topic because it's self-explanatory. I don't think I should go too deep into this. With that brief introduction, I would like to call Dr. Emma Wilmot from the United Kingdom. And she's an associate professor at the University of Nottingham, honorary consultant diabetologist, the University Hospital of Derby, and the Burton NHS FD founder. She has worked a lot on diabetes technology network in the UK. She has over 100 publications and her research interest includes diabetes, technology, structured education and type 2 diabetes in young adults. Dr. Emma Wilmot, the podium is all yours.
Thank you very much, and thank you to the IDF for inviting me to speak today on CGM for detecting dysglycemia in people with pre-diabetes. These are my disclosures. So we're going to explore the role of CGM in detecting dysglycemia. You'll be aware that we now have wide access to CGM in many countries for people with type 1 diabetes and increasingly in type 2 diabetes. But we're also seeing more and more people using CGM that don't have diabetes, and understanding where we stand as clinicians with those glucose levels outside the context of diabetes is challenging, and I'm going to be exploring that in more detail today. I'm going to explore some of the practicalities, the evidence base, and most importantly, the future possibilities in this area. So I don't need to tell this audience about challenges with pre-diabetes. This is a global phenomenon. Numbers are going up year on year on year, with around 1 in 10 having impaired glucose tolerance and around 6% having impaired fasting glucose levels. Every country across the world is facing a challenge in terms of preventing the progression of pre-diabetes to type 2 diabetes. We know that about 1 in 10 adults with pre-diabetes will develop type 2 diabetes in a given year, and up to 70% will develop type 2 diabetes within their lifetime. The whole aim is for us to prevent the progression into type 2 diabetes, and what we want to do is what's demonstrated here on the right-hand side. As people develop pre-diabetes, it's ensuring that they have the lifestyle intervention they need to prevent the progression and take them across into remission. There have been a wealth of randomised controlled trials demonstrating the benefits of CGM in both type 1 and type 2 diabetes. But where are we in terms of the detection of dysglycemia in pre-diabetes? So we traditionally rely on the HbA1c and the oral glucose tolerance test for the detection of dysglycemia. And there are pros and cons to this. Of course, they are established tests, established markers for diagnosis. They've got an established relationship with microvascular complications. They're relatively inexpensive and they're very much embedded in the care that we deliver. But there are some distinct drawbacks to be aware of. We all know that a number of people are out there with pre-diabetes and are not yet diagnosed. And the barrier of having to come to the clinic for a blood test is a key concern. We also know that we're meant to be doing OGTTs in a standardised approach, but we're all too aware of the drawbacks and the fact that this doesn't often happen in routine clinical care. But most importantly, if you get the result from an oral glucose tolerance test, it is a moment-in-time result. It gives you no information about day-to-day glycemic variability, no information about the impact of lifestyle factors on the glucose values for that individual. And most importantly, gives the person with no insight as to what they need to do to improve their outcome. So we've got CGM, But a key question, is it a reliable marker and for the detection of dysglycemia? So there's actually not too many studies in this area, but the information that's coming through is suggesting that it can be a useful marker. These data from 100 predominantly Mexican-American participants with blinded CGM demonstrate what is possible. You'll see for the data for average glucose variability, time in tight range 70 to 140, and time in range that there's a progression of glycemia from at-risk to pre-diabetes to type 2 diabetes. But in this study, the only marker that was showing a significant difference was glycemic variability. So although we get that progression in glycemic measures, actually if we're going to start thinking about CGM for detection, we need some more data to understand where we're at. You may be aware of this paper from Timothy Dunn and colleagues, which really gives some useful insights into the potential role for time in tight range as a discriminator of prediabetes compared to type 2 diabetes and normal glycemia. If you start with the top line, the black line, this is a marker for time in range, and you'll notice that as we move from those with prediabetes into type 2 diabetes, there's not that much of a shift in the numbers. However, if you look at the red line, which is time in tight range, 3.9 to 7.8, you can see that there's a very sharp fall as we move into prediabetes, suggesting that this would be a better discriminator for those developing prediabetes and then type 2 diabetes. So it's got potential. More work needs to be done, but CGM certainly has potential. CGM gives a wealth of glucose data over that 2-week period rather than being reliant on that one point in time. Some people may find it easier to wear a sensor for a fortnight than come to a clinic to get a blood test done. And also that might support with better detection. The potential perhaps to overcome clinical inertia. And of course, the ability to review the data remotely, which for those of you who look after patients over a wide geography, has certain advantages. But there are some other drawbacks. We know that a lot of people go out, buy sensors and come into the doctor saying, have I got diabetes? But actually, if you really want to be thinking about this as a diagnostic test to pick up dysglycemia, you need blinded sensor data so that the patient can change their activity, change their diet to impact on the results. We also need high quality sensors if we're going to be using them for diagnostic purposes. Not all glucose sensors are the same, and myself and Chantel Matthew and many others from across Europe have recently published a paper as a call to action suggesting the need for a minimum set of standards for using glucose sensors across the population. There are potential cost implications which we need to investigate as well. And you'll also be aware that the IDF have recently introduced the 1 hour glucose target of 8.6. And at the moment, there are no CGM studies investigating this in the context of pre-diabetes. So lots of work to be done. What about CGM as a potential intervention in pre-diabetes? Well, again, surprisingly few studies out there. We have feasibility studies showing that people find it positive for behaviour change and that it improves their understanding of glucose levels. And we also have a pilot study showing high satisfaction and improvements in HbA1c and weight. But the randomised controlled trial that we have of CGM in prediabetes provides some interesting results. Now, overall, they were able to show no change in time above range, but they were able to improve time in tight range. And the reason that they achieved that was there was a reduction in hypoglycemia. So the opposite of what you and I would have expected. We'd have expected the reduction in the hyperglycemia. Actually, it was a reduction in the lower glucose values, which drove that change, raising questions as well about whether hypothresholds that we use in diabetes are as applicable in the pre-diabetes population. So overall, there are many unanswered questions, and actually Viral Shah and David Kerr from the USA have beautifully summarised where we are at the moment with some of the key questions they've posed in this recent paper in Lancet Diabetes and Endocrinology. Are the glucose spikes that we see on continuous glucose monitoring implicated in diabetes risk or progression? We don't know yet. What are the most useful CGM metrics? It looks from the data that I've presented, like time and tight range might be a key marker, but actually we don't know for sure, particularly when we're looking across age ranges, genders, race and ethnicity, and this urgently requires more detailed understanding. What about asymptomatic hypoglycemia, something we see on many people that wear sensors and come into clinic panicking that they've got lots of hypos? We really don't understand what the long-term implications of this are with sensor-detected hypoglycemia. We also, as I've shown you, we still don't know whether CGM can facilitate the required behaviour changes to prevent progression to type 2 diabetes, and we need to understand that. And finally, is the target range of 54 to 140 milligrams per deciliter applicable to this population? We use it in diabetes, but actually this may be a better target range for those with pre-diabetes, but further work is required. So in conclusion, CGM is very much the standard of care in type 1 diabetes and type 2 diabetes, and it has got the potential to be a useful tool for the detection of dysglycemia, but ultimately we need far more research to really understand which metrics are most useful and what the role is in people with pre-diabetes, particularly in the context of prevention. Thank you very much.
Thank you, Emma. I think you can hear me. Thank you very much for finishing on time. I have 2 questions on the slide over here. But before that, did you see any difference between the 2 genders? Because youngsters, hormonal changes in pre-diabetes, boy versus girl, men versus women. Did you see any changes in the behavior pattern, especially when they use CGM?
So at the moment, we've only got that one randomised controlled trial, and from my memory, there weren't sex differences. But again, this is something we're going to need more work in. I think the study that was there was predominantly a male population, so we need to get more balanced studies to understand whether there is differential effects between the sexes.
Okay. If the patients are asked to pay money from their pockets, how many do you think will actually wear a CGM in UK?
So in the UK, that's ultimately the situation at the moment. We certainly don't have national funding for this, but we do increasingly see people buying sensors out of their own pocket. And this is a challenge that we as clinicians have. They come in showing us the data, and trying to give advice based on that is actually very difficult at the moment. And I think the reality is we need to rely on the existing tests of HbA1c and glucose tolerance to be able to make any decisions about whether they have pre-diabetes or diabetes.
Anyway, it's interesting. There's a question here. Is there any difference between diabetes complication prevalence for people with pre-diabetes achieving TITR versus type 2 diabetes achieving TITR? I suppose it's time in range.
So in terms of pre-diabetes and the data for time and tight range and time range, I've not seen those. I don't think there are any publications looking at that at the moment. The Timothy Dunn publication, certainly the largest numbers, but that was taken from the Libre data that's in the cloud, so of course doesn't link to real world complications. For the researchers out there, I think this is an area ripe for lots more research, because there's more questions than there are answers at the moment, I believe.
Okay, I'll just join 2 questions, because this is the last question we can take before the next. Okay. Although the data is very scarce at this point of time, and the use of CGM in pre-diabetes is not really practiced worldwide, regardless of what's available as evidence, what's your take-home message?
My take-home message is wait until we've got more data. So, for example, I run a diabetes antenatal clinic. I have women with gestational diabetes who purchase the sensors. They then see their glucose is 3.5 overnight, get up in the middle of the night and drink sweet juices. I think I'm worried about the fact we don't understand what is normal in this group, and that people are reacting, as we saw in the randomised controlled trial. They're reducing the hypos, but actually we don't know that that's of benefit in people that aren't on agents that put them at risk of significant hypoglycemia.
Thank you, Dr. Emma. I think you can be seated now, and then if you have time after the 3rd lecture, I'll call you back. And the second topic is very, very important, is PGG control. Is it still useful? I think this is a question in everybody's mind. To talk about it is Dr. Yutang Wang from Australia. I mean, Wang is a senior lecturer in biomedical sciences in the Federation University of Australia. He is named in the 2023 and 2024 Stanford's list of world's top 2% of the scientists. Give me a big hand, ladies and gentlemen. And Wang, I want to ask you a question before you start. Are you single?
Oh, no.
Okay, so I think you can start your talk now. PGG control is still useful. It's over.
Yeah,
to
the
you.
answer
Thank
is
you.
please. Okay, yeah, that is true. Good afternoon, everyone. Thanks the introduction from the chair. Thanks the organizers to give me the opportunity today to share my research. Today I'll talk about postprandial blood glucose. So PPG, whether postprandial glucose is still useful. PPG is believed to play an important role in disease control. It has been shown that 1 hour and 2 hour PPG levels after breakfast or after lunch are associated with CVD events. There are plenty of publications there. However, there are some challenges in using PPG to guide clinical practice. For example, examining PPG at a set time point, either 1 hour or 2 hours, is less practical in large-scale screening studies or large-scale epidemiological studies. For example, the variation in blood collection, the variation is about 30 minutes. That means 1 hour PPG was measured between half an hour and 1.5 hours. So during that time range, the blood glucose could vary quite a lot. Secondly, the variation in diet can change PPG more than 20 milligrams per deciliter. Here shows the PPG, the blood glucose level after a meal. So we can see the PPG levels are dynamic. After a meal, the blood glucose can quickly increase, then gradually decrease. We saw that during 4 to 7.9 hour time period, blood glucose back to roughly to the normal level. And therefore, we propose to investigate the usefulness of PPG 4 to 7.9 hours, which is a non-fasting measurements. First, here we studied the stability of PPG. Here, from the literature published by Eichenlob et al., and they included 22 healthy individuals and give them to 3 meals every 4 hours. The top panel, they showed the standard diet. This is the breakfast, 4 hours later lunch, then dinner. You can see blood glucose returned to normal within 4 hours. The bottom panel shows that when the participants were given high carbohydrate diet, we can see blood glucose, even though they can maintain high longer, but they return to baseline 4 hours later. We did some research recently and found that during 4 to 7.9 hours after meal, the hourly plasma glucose levels were similar. Also, PPG 4 to 7.9 hours, their levels correlate with A1C. Just to summarize the characteristics of PPG 4 to 7.9 hours, it may represent a homeostatic state, irresponsive of meal composition or timing. Therefore, it offers a promising window for assessment. One question we want to ask is, does PPG 4 to 7.9 hours predict disease outcomes? The answer is yes. We found that PPG 4 to 7.9 hour predicts cancer mortality. Those results were published in EMRR last year. In this study, we included 14,860 participants who are naive to anti-diabetic medications. Some participants, the blood plasma glucose were measured between 0 to 3.9 hours after meal. Some had PPG 4 to 7.9 hours, and the majority participants had fasting plasma glucose. Also, some participants had a 2-hour OGTT test. Out of those plasma glucose parameters, only PPG 4 to 7.9 hour can predict cancer mortality after multiple adjustments. What are the PPG cutoffs? We use the A1C as a reference. Normal is less than 5.7%. High A1C is 6.5% at above. And use this reference, we did a ROC curve analysis and found that a normal cutoff is 94 milligram per deciliter. A high PPG 4 to 7.9 hour is 101 milligram per deciliter. Do those cutoffs apply to cancer mortality? The answer is yes. We can see that this is the Kaplan-Meier survival curve. You can see those with a higher PPG at or above 101 milligram per deciliter, they had higher cancer mortality compared to normal. Those results remained if we we justified for multiple confounding factors. Also, all-cause mortality analysis validated that those cutoffs, you can see those with a higher PPG 4 to 7.9 hour had a higher all-cause mortality compared to with a normal PPG. How does the 101 milligram per deciliter PPG 4 to 7.9 hour correspond to fasting plasma glucose? We searched literature and found 2 relevant studies from Avignon and Peter. You can see this is the fasting plasma glucose levels. Those are the PPG 4 to 7.9 hour. We can see that fasting plasma glucose is about 27 milligram per deciliter higher compared to the PPG 4 to 7.9 hour in those with a mild type 2 diabetes. Therefore, 101 milligram per deciliter PPG 4 to 7.9 hour is roughly 128 milligram per deciliter in fasting terms. So this is just about the current cutoff for fasting plasma glucose, which is 126. We further did the study which was published in JCDD last year. We found that PPG 4 to 7.9 hour predict CVD mortality as well. Lastly, we studied whether PPG 4 to 7.9 hour can be used as a diagnostic marker. We found that maybe it can diagnose diabetes as well with a high accuracy of 87.3%. In summary, PPG 4 to 7.9 hour is stable and correlates with A1C, predicts mortality from cancer and CVD. It may be useful diabetes diagnostic marker. This parameter is non-fasting, and therefore it may be comfortable and convenient for patients. Finally, we would conclude that it may be useful to explore its true clinical use in the future. I would like to thank the collaborators from various institutions, and also thank the funding from NHMRC. Thank you all for listening.
Thank you, Wang. Well, I have no questions as a chair, but then I have a few interesting questions which has come here. The first question is, was there an association between elevated postprandial levels and elevated lipid levels?
That
Because
one,
you did mention about CVD risk and that and all that, so we just want to know.
we did not do the thorough analysis, but from the baseline, without adjustment, the higher PPG correlated higher the cholesterol levels and also triglyceride. But we did not do a thorough investigation regarding the multiple adjustment.
Okay. So the next question is, have you studied if the postprandial glucose 4 to 8 hours approximates mean glycemia? The correlation to HbA1c appears less tight with lower or 2s than the mean glycemia in the usual ADAG equation. Well, I mean, whoever asked the question, can they stand up and make it a little more clear to the speaker, please? Okay, now, who asked the question? Have you studied if PPG 4 to 8 hours approximate mean glycemia, and then how do you get the correlation and what have you used for the correlation? I have the question here which appeared. Somebody has asked the question, but okay, if you're not clear, I'll just go to the next question. Okay. How do we measure postprandial 4 to 7 hours? Do patients fast for the rest of the day after taking the first meal?
Yeah,
That's a funny question. Even I had that in mind.
Yeah, this one is the after fasting. Yeah, this is the after meal. When you go to the doctors, after meal, they do not eat any calories. You can drink water, but no calories, no sugar drinks, and then counted as the 4 hours after the meal. So start there, and then we have 4 hours, and then last for another 4 hours.
Okay. The last question is a little funny question. I mean, what's the advantage of doing PPG when you have told us that it's comparable to HbA1c? Why do it 4 to 8 hours later?
So the reason for that we can see from the cancer mortality. We had the 2-hour OG-GT data, but that one does not correlate to cancer mortality. Even the fasting plasma glucose, the thing like PPG 4 to 7.9 hour is more sensitive to detect cancer mortality.
I hope that answers the question asked. I think we have another 1 minute if anybody has a question to ask on this particular lecture. Okay, if there are no questions, thank you very much, Yang. I think you can be seated down, and then if you have time, I'll request all the speakers to come. Dr. Amit, will you come and take the stage as I introduce you? Dr. Amit Kumar De is a very distinguished physician specializing in diabetes, obesity, and metabolic disorders, based out of Kolkata, India, and has been recognized as a person who has contributed a lot to diabetes and technology. And he has an American board of Artificial Intelligence in Medicine and is a fellow of the Royal College of Public Health in the UK. And he has done a lot of work, especially with artificial intelligence and how to use it in our day-to-day clinical practice. And he'll be talking about digitalization and AI in diabetes prevention. That's going to be interesting. Over to you, Amit.
Thank you very much, Professor Arvind, for the kind introduction. Greetings from India and from where I come from, the city of joy, Kolkata. So we all are quite hyped about the use of digital therapeutics, digital health, technology, and of course, artificial intelligence. We know that it can do wonders but do we have the science and the evidence to? So folks, over the next 10 minutes is going to be my job to show you the science and let you weave the evidences around. Well, these are my disclosures. As a person who's advocating the use of artificial intelligence, a lot of AI has gone into making this presentation. We will be speaking about some proprietorship models, but I do not intend to endorse them solely for the purpose of illustration. This is from the latest 2025 IDF Atlas, which has just been released yesterday, and the global burden has just gone up from 583 million to 589 million. We are looking at probably an unmet population of pre-diabetes more than 9%. And of course, if you're looking at the type 1 diabetes population, they are all at a risk of developing diabetes. So there is a lot to do, but the question is, can technology help us in solving this somewhere? Let's quickly look at some of the unmet needs which exist when we try to prevent diabetes or even prevent the complications. And I think one of the biggest unmet need is screening gaps, because many individuals will be at a high risk and they have been never screened. And there has been the US DPP, Diabetes Prevention Program, which showed, and the paper and the publication showed, that this program were underutilized for various reasons. And this means that there is always going to be dropout from such interventions. There is also unmet need that there is limited personalization. So if you have a standard screening protocol, one for all, sometimes it does not fit all. So we need something which is much more personalized, and there is always going to be disparities in uptake. There's going to be limited uptake in the various segments of the community. What about type 1 diabetes complication? And I know that individuals living with type 1 diabetes would vouch for it, that it's always easier said than done to manage their blood glucose level, because controlling the glycemic fluctuation is the key in preventing the complications. There is also delay, and especially talk about the low and the middle income group countries. In the IDF platform, we are looking at screening delays of retinopathy, nephropathy, and neuropathy. And there is also limited access to technology in most countries, because there is a lot of inertia both from the patient side as well as the healthcare provider side. This adds up to the burden of managing and treating the complications, but there is always a window of preventing it when there is good time for it. So the question is, why do these traditional methods fall short? Because we've seen from the US DPP program that there's a lot of dropouts in lifestyle intervention. In-person models will require time, travel, and staffing. There's lack of personalization, which I spoke about, and health system will lack the bandwidth to proactively manage high-risk individuals. So there is where digital solutions can come into help for us. So digital solutions can automate, it can personalize and scale interventions. Well, we all know this. We also know that there is a prevention window. My topic is AI and digital health in diabetes prevention. So this undiagnosed pre-diabetes population that suffers or exists in the community for 5 to 10 years can be picked up, screened, and treated if we use the right digital health solution at the right point of time. So this opens up the window of digital health and as an opportunity, and this missed screening can be picked up in the most cost-effective way. But the question that I will try to answer is, do we have the evidence to show that digitalization and artificial intelligence can solve some of these challenges? Now take a look at this study which I'm going to show you, and this particular paper has actually showed that 43% of the patient achieved more than 5% weight reduction with a digital diabetes prevention program plan. And this is what was the conclusion of the study, and it was quite statistical significant. Take a look at one of the other paper which also showed similar HbA1c reduction and improvement in terms of as compared to that with the personal contact prevention program. So now we have some evidences to show, and as I go forward, I will show you some more evidences which proves that yes, digital solutions can work. What about text messaging and simple messaging services? So SMS feasibility and messaging apps are simple to use, cost-effective solutions which are available in most countries, whether we talk about a high-income group country or a low to medium social income group country. And this can be also scaled globally. And there could also be the opportunity of using hybrid solutions. So you have one in-person consultation followed by a follow-up using technology and messaging solutions, with telecoaching coming into existence intermittently. And this is a paper that talks about the same. Let's understand about artificial intelligence. We all so far understand what is artificial intelligence, but why do we need to talk about AI in the healthcare segment, especially in preventing diabetes and diabetes complications? Well, the reason is this. All that we've been speaking about, talking about in conference, in our practice, is the tip of the iceberg. That is the evidence-based medicine, evidence-based diabetology. Possibly for the first time in the history of medical science, we are going to be looking at data-driven, intelligence-based precision diabetology with the help of artificial intelligence. And this is the sole reason why we all must explore using this powerful technology into understanding this disease better. So there is a huge spectrum of using AI in diabetes management, whether you talk about disease prediction and risk stratification, using self-management education. Diabetes self-management education is a big limitation in insulin treatment support, in the continuous glucose monitoring pump, and also in screening for diabetic retinopathy and other complications, in diabetic foot ulcer screening, and of course in the clinical decision support system. The biggest advantage of using AI is that it can predict using machine learning, and we have papers and we have articles which shows that machine learning models can actually predict and stratify the risk of an individual developing diabetes as effectively as a conventional statistical model would prove. This will help in early identification using supervised learning, and this can also be used for multi-ethnic validation with the right clinical implementation with the clinician in place. This is the paper which talks about using a machine learning tool in China, and this is a fantastic paper where they have predicted the risk of the individual developing diabetes, and it's a nationwide cross-sectional, from the nationwide cross-sectional data. Why does type 1 diabetes patients need artificial intelligence? We've spoken about glycemic variability, the psychological burden. Diabetes self-management education can actually be enhanced, and prediction of the glucose patterns can be done in a most personalized way, because this is the reason. The problem is one-size-fits-all approach does not work in type 1 diabetes management and even in type 2 diabetes management. So we need a tailor-made solution for each patient, and NLP, natural language processing, can actually empower us to reach that place. As a result, enhancing patient adherence to the treatment and bringing better glycemic outcome. So we are looking at diabetes education with the help of artificial intelligence through personalized learning, chatbots and virtual assistant, and the concept of gamification. Now, we understand something called just-in-time adaptive intervention, which is if you are intervening to the patient with the right information at the right point of time, you're going to make a clinical impact in the behavior of the patient and thereby bring impact in his glycemic outcomes. Well, artificial intelligence with the help of natural language processing can help us exactly do the same. This is one of our publications that came out last year where we actually explored a conversational AI large language model, famously known as ChatGPT, which you're all aware of, if it can actually help in diabetes management, diabetes care as a potential tool for diabetes self-management education. The QR code on the right will give you access to this free paper you can read at your convenience. Well, we also went a step ahead where we had a group of clinicians developing something called Madhu AI, which is Metabolic and Diabetes Health Assistant, which is in a research mode and validation mode at the moment. It's a WhatsApp user interface-based chatbot. At the back end, there is a large language model that works on it. It's basically a patient education platform imparting diabetes self-management education. We went a step ahead and we validated the response of Madhu AI with the help of clinicians. About 100 clinicians across the country participated in the validation, and they validated the response given by this AI chatbot in terms of its coherence, in terms of its relevance, in terms of its intent to do any harm, and many more points. And of course, this is an unpublished data. I will request none of you to share this, but we are going to soon publish the random validation result, and we will be going forward to do a standardized validation of a chatbot like this. What about retinopathy screening? And this is a paper published in Nature that shows that RCT shows that there's 100% screening completion with artificial intelligence versus traditional referral completion, which is just 22%. And as a result of this, in 2018, FDA approved the IDX stop confundus camera for diabetes retinopathy detection. And since then, there has been multiple work and multiple application of using deep learning convolutional neural network for screening for diabetic retinopathy and its complications in the community. This was one of our work we conducted in the city of Kolkata with 5,000 patients. We did a community screening of diabetic retinopathy, and the prevalence we found was 13.7%. Now, we also have CGM-linked AI apps which can give real-time guidance and bring improved outcomes by predicting the pattern of the glycemic variation based on the inputs which the patient is giving, and this is using machine learning and natural language processing in the back end. And this paper, which is a work of January AI, kind of speaks and puts the evidence behind this working. We are also aware that now we have closed the loop and there is machine learning that works behind it. We are talking about the bionic pancreas, and this is a publication that has recently published which shows 0.5% improvement in HbA1c in closing the loop. And of course, there is telehealth and remote monitoring coaching, which goes along well. In COVID-19, we have seen that this had played a very important role. So going forward, there is precision prevention with artificial intelligence, with digitalization, with adaptive learning, and personalized care in precision application. But for this, there's going to be a lot of challenges. It's easier said than done. There has to be workflow integration. Alerts, fatigue will have to be taken care of, and more importantly, we have to take care of data interoperability. So to overcome this, there's a lot of biases that will come on, then we have to mitigate strategies for overcoming these biases as we go on. And of course, the question is about privacy and data governance. And as we evolve with technology and artificial intelligence, we as clinicians in the forefront must have a role to play in how the data and the privacy policies are going to be working. There needs to be the human in the loop, and human oversight in AI tool is very, very important for explainability and for making sure that the AI model is giving the right output at the right point of time. Equity and digital divide has to be there to custom-tailored digital solutions, because the true essence of technology is when it is available to one and all, whether it's in the rural or in the urban setting, whether it's in low-tech solution areas or in areas who can afford technology solutions. There has to be regulatory and ethical oversight, and at the International Diabetes Federation, I would like to focus on these three segments where we can work together. And recently I have been entrusted with the committee of the AI in International Diabetes Federation to lead the committee, and this is what we will be looking at, working towards evolving standards, validating the responses, and establishing ethical principles. As a result, we will be able to bring a scalable solution in low and middle income countries with the help of IDF, because we strongly believe that the true essence of technology and artificial intelligence can only be utilized if it is available, affordable, and accessible to one and all, both the patients and the doctors. For this, we need to train the clinical workforce, and we will be working hand in hand with the IDF school to ensure we are going to be doing that. So these are my key summary points as we come to the close, that there is a window of opportunity where we can utilize artificial intelligence and digital health, and we can actually prevent the complications and prevent diabetes from occurring. And this is a call to action to all of our audience and to everyone at IDF. We believe that digital and AI technologies will be reshaping diabetes care, but as clinicians in the forefront, we have to be informed, proactive, and we have to be ethical, and we have to know what we are adopting. So researchers should come forward and validate these real-world effectiveness and safety, weave the evidences around it. Policymakers need to enable equitable scaling of digital and AI tools, and together we can move ahead towards a future of precision prevention. Thank you very much.
Thank you, Amit. I think your last line said it all. There are issues, there are problems, there are challenges, but I think we need to move on. And at some time, it's going to be the precision thing. There are a few questions here. I mean, there's an interesting question. You know, most of my patients think that it's not a Candy Crush to be looking at the mobile phone most of the time. How do you suggest breaking down the stigma barriers so people can learn about their opportunities to access care? Because areas change geographically. Many countries like India, every 100 kilometers it changes. So is the case with so many countries. how do you think we should break this stigma down, making people use the technology to improve their care?
Well, I will simply say this, that India is a country that has actually shown the way to the world that technology, the use of technology is not a barrier based on your education status or based on where you're staying, because India has adopted the unified payment integration gateway in a great way across different segments of the society. This is an example which goes on to show that every individual has a very powerful tool in their pocket, and this is what Peter also says, that our pocket has something very important, our mobile phone. And with the help of technology, with the help of artificial intelligence, using natural language processing, which means that the AI system can talk to you in your language in the way you want to be spoken at. This is a powerful technology that we can utilize to bring that impact and take away that inertia of the patient in adopting the solution.
Yeah, another last question, quite interesting, because AI tools are generally done country-wise, because every region, every country is different, and if you need to personalize the answers, the intervention has to be personalized. How do you think you're going to actually make this machine learning do this? Because constantly things are changing in the world, because there has to be somebody. It can't be one program for all. I mean, it has to be absolutely country-wise. How do you think IDF is now going to look at it? Because what works in India may not work in Canada, what works in US may not work in Pakistan. I mean, all of us are different, right? So that's what the question is. There's so many cultural nuances, various countries, developing AI tool itself appears to be a big headache. Now you're the chair of the IDF AI committee. How do you look at it? Where do you start from?
Yes, I think this is a brilliant question, and I just want to point out to one very important thing, is that we are looking at that spectrum of data, from data to information and from information to intelligence. Now, what is at the moment the biggest limitation is that we do not have country-specific, geographic-specific data. Most of the AI tools which are built on open source data, which may not fit and in a tailor-made way into certain countries. So what we first need is the data, and with the data, country-specific data, we can actually encourage to build tailor-made specific solutions. One very important aspect is validation of that solution based on the local regional guideline, such that the utility of that machine learning algorithm is going to be very specific. Second part of your question is actually very interesting, where you ask that how does the tool keep on refining itself? And this is where the concept of reinforcement learning with human feedback comes into place. It is a segment of generative AI where the AI model keeps on learning on its own when it is interacting with you with the help of natural language processing. So for folks who have been using your GPT or Gemini or your Meta, you would see that the personalization is happening each time you are asking a question. Each time it gives you back the response in a personalized way. This is where RLHF works, and that's called reinforcement learning with human feedback. And this is going to play a very important place in medical science and diabetes care, which we will be using to evolve these tools in a geographic specific way.
Thank you, Amit. And good afternoon, ladies and gentlemen, my colleagues.